Right. Good evening, friends. In this session, I'll be discussing about the topic esophageal perforation. Under this topic, we'll be discussing about the causes of esophageal perforation, and we'll be discussing about the clinical features and the investigations and the treatment. The first point which we need to understand here is the causes of esophageal perforation. The cause can be an iatrogenic, it can be a spontaneous, it can be foreign body, it can be trauma. Now, in the first point of iatrogenic, it can be during the diagnostic therapeutic procedure. Like if you do an endoscopy in such conditions also, it is you can get an esophageal perforation. So they can ask you the most common cause of esophageal perforation. The most common cause of esophageal perforation is iatrogenic. Iatrogenic. That is mostly endoscopic perforations. The next point which we need to understand, which we'll be discussing, that is a spontaneous, and we'll be discussing about how the foreign body and the trauma, right? So in the introduction we need to understand few basic important points. Okay, now what are the basic points which we need to understand? Now you know that esophagus is divided into three: cervical esophagus part, thoracic part, and abdominal part. Now I have discussed here the iatrogenic most common site is in the iatrogenic, the most common site is cervical esophagus. So example, now say exam they can ask you what is the most common site of esophagus for the esophageal perforation, and your answer should be cervical esophagus. And what is the most common cause? The most common cause is iatrogenic instrumental, that is endoscopy, right? So the thing which we need to understand, now say example you have a perforation at the thoracic point. Now what exactly happened? Where is the thoracic part of the esophagus? The thoracic part of esophagus is placed at the mediastinum. Now say example if there is a perforation at the thoracic point, what actually happened? And this a patient can present with vomiting sensation. The present not a vomiting sensation, the patient presents with vomiting, the patients present with chest pain, and the patient present with subcutaneous emphysema. Now these three important points, right? These three important points, the patient can present with your vomiting, present with the chest pain, can with some subcutaneous emphysema. So, and this triad of vomiting, chest pain, and subcutaneous is known as McLeod's trait. Right? And the important sign which we need to understand in the X-ray is Necklerio V sign. What is Necklerio V sign? It is a V-shaped gas present at the cardiophrenic angle, and which tells you this there is a pneumomediastinum. So this is an X-ray which tells, okay, this is the X-ray, right? This is an X-ray which tells there is a Necklerio V sign. What is Necklerio V sign? Now if you observe carefully, there is a loosened band of a gas extending along the descending aorta, right, and intersecting, and remember that an intersecting band of gas that extends at the medial aspect of the left hemidiaphragm, forming a V shape. So this is the V shape, right? You can see this V shape, the bit of vertical. So this V shape is because of a gas along the descending aorta, and this V shaped gas which is present at the left hemidiaphragm. So these are the points which we need to understand. And the next important point is the patient can have a perforation. The patient can have a perforation, and the perforation can be at abdominal esophagus. In the abdominal esophagus, the patient has a triad that is known as Anderson's triad. What exactly happened in the Anderson triad? Now, once there is a perforation in the abdomen, and that leads to peritonitis, And you know that once there is a peritonitis, you can see there is an abdominal rigidity, and the respiration will be rapid respiration. And this patient can also have a subcutaneous emphysema. Now, what is the X-ray finding here? The X-ray finding in the peritonitis is air under diaphragm. So these are the two basic points which you have to understand. One is McLeod's traits. Next is Anderson. Okay, Anderson. What is the sign you find in McLeod's? That is V-shaped sign. That is Necklerio's. That is the Necklerio's V sign. What is in peritonitis? It is air under diaphragm. Now, these are the points which we need to understand in the clinical aspects, right? Clinical aspects. What can be the other aspects also? Another, the patient can have, I've told you the patient has a vomiting sensation, right? Can have a vomiting sensation, says have a pain. Then I've told you in the X-ray findings you have, right? X-ray finding. Now, what exactly happened in X-ray? You can have a subcutaneous emphysema. What emphysema will be in mediastinum? So, mediastinal emphysema is present after 1 hour of perforation. What is mediastinum widening? So widening in the sense the structure present in the mediastinum widens, and this widening of mediastinum is seen after 2 hours. It is secondary to the edema. Second to the edema, you find a mediastinum widening, right? You even have something known as cervical emphysema, right? You even have something known as cervical emphysema, and this cervical emphysema is present at the erector spinae muscle, right? Erector spinae muscle. It is because of pneumothorax, because of pneumothorax. So these are the X-ray findings which you need. They can ask you the X-ray findings. The X-ray findings they can tell you. We'll be discussing X-ray, but X-ray findings, any mediastinal emphysema is seen after 1 hour, and you can also see what mediastinum widening because secondary to the wall, secondary to the edema, cervical emphysema. It is along the erector spinae, erector spinae, cervical emphysema. In erector spinae, you have a pneumothorax. Remember, you have a pneumothorax because of pneumothorax. Now let us understand how do you manage these cases, right? In general, how do you manage the case? Now, before that, which I have already discussed about the iatrogenic. Now, let us understand a few important points. Then we'll be discussing about the management on the investigation, and it can be because of spontaneous esophageal perforation can happen. What is spontaneous esophageal perforation? The spontaneous esophageal perforation is known as Boer-Haave syndrome. Boer-Haave syndrome. In this, what actually it is seen in the 15% of cases, and it is highest mortality. It is due to there's a delay in the diagnosis and treatment. Okay, and occurs into left pleural cavity or just above the GE junction, and associated with GERD sliding hernia. Now, after it's also written there. What is the pathogenesis? The pathogenesis is increasing in the intra-abdominal pressure against the closed glottis. Now, what is it trying to tell us? Okay, what is it trying to tell us is, now, what example? This is a point which we need to understand. This is an esophagus. Okay, esophagus. Now, against the closed glottis, you have a glottis, right? Epiglottis. Against the closed glottis, if a patient vomits, okay, if the patient vomits, and there can be a rupture. What happens? There can be a rupture at the lower posterior esophagus. There can be a rupture at what? At the lower posterior aspect. So lower posterior aspect, and it is seen in 15% of cases. 15% of cases, and this rupture is because of the vomiting against the closed glottis. Where exactly the rupture happens? The rupture as the lower posterior, at the lower posterior esophagus above the GE junction. And you have a sign here which I've already discussed, that is Mecklier's sign is seen in this Boer-Haave syndrome, because the perforation is in the thoracic part, right? So the person have vomiting, chest pain, and subcutaneous emphysema. And in this Boer-Haave, the whole length of the esophagus is problematic. It is a cut section, right? Cut section. So it comes. Now, what is the treatment for this Boer-Haave syndrome? The treatment for the Boer-Haave syndrome is the immediate surgery, because you can have this mediastinitis, and there can be a heavy chest pain and other complications. There should be an immediate surgery. Now, why there is what do you do in this point? Now, it's also divided like, and there is something known as golden period, right? The golden period is 24 hours. Now, the edges. Now, if the bed is healthy, that means if the esophagus, the muscles are healthy. Now, there you can do a direct repair. Less than 24 hours, you can do a repair actually. Now, if example, if you have bed is unhealthy, where you cannot repair the ruptured part. Now what you do is you do something known as esophageostomy. Where what is esophageostomy? It is an manual way of putting the hole in the esophagus, and you put a tube. Okay, so the feeding can start. Okay, and you can have something as thoracostomy. Thoracostomy, where at the thorax you make a hole. Omi is a hole made at the thoracic point. So these are the two basic points which you need to understand in the perhaps syndrome, right? Borap syndrome. So that's what it's trying to tell us. The rostrinum, that is 15% of cases, that is highest mortality. Why is highest mortality seen in Borap's cases? Because of late diagnosis and the treatment here. And what does it do? It occurs into the left pleural cavity, and where exactly about? Just above the gastroesophageal junction. Gastroesophageal junction, and this is associated with GERD, gastroesophageal reflux disease, and is also associated with sliding hernia. Sliding hernia, right? And the pathogenesis I've told you: acute increase in intra-abdominal pressure. The acute increase in intra-abdominal pressure against the closed glottis, increased in the intra-abdominal pressure. Right, just remember the pathophysiology. It is an acute. Okay, yeah, it is an increase in the intra-abdominal pressure against the closed glottis. Remember, against the closed glottis you have this, and this is the pathogenesis. Okay, now even the foreign body can lead into the esophageal perforation, that is 14%, and even trauma can happen, this 10%. Now let's not worry about this. And the next important, here have something known as Mallory-V syndrome, where there is a mucosal tear, then there is a bleeding, occurs in rolling hernia. And what's written here is longitudinal fissures in the mucosa of herniated stomach and at the gastroesophageal junction, mostly of conservative. Now surgery, you can see what. Okay, you have got something known as we have a tubes here, right? A Sengsten Blue tube. You have endoscopic epinephrine injections. If that fails, you do a surgery, that is an overswing. Okay, we'll be discussing that in detail, but for time being, you understand the management, what you do with the esophageal rupture, guys. Okay, and how do you investigate? The investigation of the choice here is early or suspected perforation. In the investigation of choice is CT with oral contrast. CT with oral contrast. And what type of contrast you use here? In gastrointestinal contrast, you need to understand the whole of the gastro. We use of three contrast. One is barium sulfate, that is water insoluble, and you have water soluble contents. What are the water insoluble? The water insoluble are barium sulfate. Now what exactly happens in the barium sulfate is, now barium sulfate, it is a gold standard. Remember, you have a gold standard. Gold standard is barium sulfate is a gold standard, and you should also understand the contrast of choice. So what they can ask you, the what is a gold standard for the esophageal perforation, that is a barium sulfate. They can even ask you the what is the contrast of choice in the esophageal perforation, and you should tell it is a barium sulfate. And why it is? It is 100%. It is an 100%. What exactly happens here is it is an 100%. In this 100% sensitive, right? That's a point we need to understand. It's an 100% sensitive. That is, what do you mean? It correctly, okay, correctly identifies where exactly, or whether exactly the perforation happens or not. Where exactly? In the barium sulfate, again, it is of thin type of barium sulfate, and this thin type of barium sulfate, it is to look for the perforations, and thick type to look for the motility disorders. So the barium sulfate, the thin barium sulfate is used for the perforations, and thick it is used for the motility disorders. Now we should also understand what is the disadvantage of this barium sulfate. The barium sulfate, it causes a mediastinitis, more of mediastinitis. Now the because of absorption, okay, it is more of mediastinate causes. It remains in the chest for the long period, so the further it further confuses because the presence of the barium sulfate in the chest that disturbs the diagnosis of this esophageal perforation. That is this is a slight of disadvantage, okay, but this is a gold standard. Next you have an next you have a contrast here, and you have contrast which is the water soluble. Remember, water soluble has got an high osmolar and low osmolar, high osmolar, low osmolar. The high osmolar has got gastrographin. Remember, gastrographin, it is used here, right? Gastrographin diathrazoate sodium. Now, if they can ask you the most commonly used is gastrographin, right? Or the first used is gastrographin. Good. Now, the first most commonly used, you can use a contrast is a gastrographin. The first used contrast is a gastrographin. But the point here is you have a disadvantage and advantage. What is the disadvantage? What is the advantage? The disadvantage is a less sensitive, right? And there is an aspiration chances happen. Pulmonary edema can happen with this gastrographin. Now, so that is the reason the pulmonary edema can happen in the gastrographin. So that is the reason it is contraindicated in comatose, unconscious, or fistula cases. In these cases of because it cause of pulmonary edema, right? Aspiration happens, gastrographin. Once there's an aspiration, now what happens? There can be a pulmonary edema. So it is contraindicated in comatose patient, unconscious patient, fistula patient. It is disadvantage. The point which you need to understand regarding the advantage is important. Now, what happens in the advantage conditions where it swallows? In the advantage is easily it can swallow. Okay. Now, I've told you the barium sulfate, more it is present in the mediastinum. Okay. Now, the less chance of mediastinitis because it is easily absorbed in the mediastinum. It won't be there in the mediastinum. So that is the reason less chances of mediastinitis, less chances of mediastinitis you can absorb well. So that is the reason we can use this most common as gastrographin. Now we even have a next contrast which is of low osmolar water solubility, that is iohexol, and mypac and monopac. Now what exactly happens in the low osmolar is important. Of isohexol, it is of safety. Remember, it is safety, and it is costly, and all the points. It is a safety. It is the safetiest, costliest. So that is the reason why this can be a choice, contrast of choice in tracheoesophageal fistula in unconscious patients and comatized patients, right? Comatized patients. Now, that's the basic points which we need to understand. Okay, which is to understand. Now, even have a next important points. So, what is a post-operative esophagogastric anastomosis? So, now, say example, a patient has a what esophagogastric anastomosis. In these conditions of which contrast to use? Say example, if it is less than 4 weeks, we use a gastrographin. Remember, okay. More than 4 weeks, we use a thin barium. It's an important question. They can ask you the post-operatively esophagogastric anastomosis. Less than 4 weeks, we use of gastrographin. More than 4 weeks, use of thin barium. Now, say example, when you use a gastrographin and that comes normal, but you have high chances of you have highly suspecting there is a leak, there is a perforation happening, and you use a barium swallow to confirm whether the perforation happens or not, right? Perforation happened or not. So that's the basic point which we need to understand in the investigations. Now now in the diagnosis point, right? In the diagnosis point, and we have something known as Pittsburgh score. Okay, Pittsburgh score. Now, this Pittsburgh score tells the mortality, right? The mortality ratio of a patient. Now, how do you remember this? You have something known as tail of hell. Okay, what is T here? What is Pitts? What is Pittsburgh score? Pittsburgh score. It is a T for tachycardia, more than 100 per minute beats per minute. A is age, more than 75 years. L, what is L? Tail, TALA. L is leukocytosis. Remember that is increased WBC count. And you have E for effusion, right? E for effusion, right? E for effusion. Now, what exactly happens here in the effusion points? That's an effusion, the plural effusion. So you go with an X-ray also, right? Tail off. O for esophageal cancer, esophageal cancer. F is fever, more than 38.5. Hell, H for hypotension. E for extravasation, right? That is used for the used in barium swallow for a non contained leak. Okay, what is L? L, you have something known as a lung compromise, that is respiratory rate is more than 30 per minute. And you have one more L. L is late diagnosis. Late diagnosis. So time of diagnosis more than 24 hours. Okay. So now what exactly happened? The points which we need to understand in the Pittsburgh syndrome, which I've told you, the tail of hell, T for tachycardia, A for age, L for what? L for leukocytosis, E for effusion X-ray, of O for esophageal cancer, F for fever 38.5, Hell, HELL. What is H? H is for hypotension, E for extravasation, HEL for lung cancer, late diagnosis or lung compromise, more than 30 per minute. Now, say example, you have a points for each of these points. Okay. Now the point here is the hypotension gives of 3 points. Presence of cancer has got a 3 points. Now total, if you add on, right, you have some conditions you have a 2, some conditions you have a 3, and if it add these points, you have total of 18 points. Now say example, you have a score of more than 5% of the Pittsburgh score, and it is 27% of mortality. 27% of mortality, which we need to understand. Now, in the same page, if you go with this, you have got something known as Mallory-Weiss syndrome, where the patient complains comes with hematemesis. A patient doesn't have any emphysema, patient doesn't have any chest pain, patient doesn't have any points, okay, but he has an hematemesis. Where exactly the point happens is there is in the lesser curvature below the esophageal junction at the cardia point, where the rupture is only the mucosa and the submucosa. It's not the transmural mucosa and submucosa. So that's the basic points which we need to understand. Now let us understand the management point. Now what exactly we do here? In the management, you have something known as non-operative of management, and you have a definitive surgeries. In the management point, where you have something known as Cameron criteria, where we non-operate management in the instrumental perforation in a small contained leak. Okay, we don't operate it. Okay, a leak drain back into the esophagus, we don't operate. Cervical esophageal perforation, we don't operate. Hemodynamic is stable, we don't operate. We have no signs of sepsis, we don't operate. Absence of pathology, we don't operate. Right? We don't operate. Like absence of pathology of a cancer or the distant like achalasia cardia, we don't operate. Then when do you operate? If the perforation is above the carina or the perforation is below the carina, a perforation is a lower esophagus. Now the perforation is above carina in the fourth, remember in the fourth intercostal space on the right side. And below carina, sixth intercostal space on the right side. What you do is you do something known as esophagectomy. In the lower esophagus, in the seventh intercostal space on the left side, you have something esophagostomy. You do an esophagostomy there. Right? We're going to try to conserve the esophagus. So remember that, okay? So these are points where you do above carena 4, you have got 6 and 7, both above are right, and this fellow is on right left. Okay, so that's what it's contained perforation. Say example, you have a contained perforation, you do a conservative study, you give a TPN, okay, you have PPI, proton pump inhibitors, and good outcomes. It comes in the primary closure within 24, which I already discussed. Left thoracotomy, I've told you, identify with the trim, we're gonna close, reinforce with pleural or fundal patch. Right, you go with the left thoracotomy, which I've told you. In the left thoracotomy, you identify, okay, make an identify, you trim it, you close with pleural or fundal patch. Now, say example, you have a more than 24 hours. In more than 24 hours, what happens here is, now more than 24 hours, you can have an edema, it's a fragile. So we can't suture it, okay. Now what do? You mobilize the end, okay. Mobilize the end, okay. That is Bowen's syndrome, where mobilize the end. You got an end esophageostomy. You can do an end, you have a cervical, end cervical esophageostomy, and reconstruction later. You can put a feeding jejunostomy can keep, okay. End cervical esophagostomy, you could do an end cervical esophagostomy, okay. The reconstruction can be done later. So these are the basic points which we need to understand in the esophageal perforation. Thank you.